Good morning, everyone. Good afternoon, good evening from wherever you're logging in from. Thank you all for joining this special webinar today. If you don't mind opening up your chat box and typing in where you are logging in from, I just activated the chat box. So hopefully you can log in, hear me, see me. And if you're on YouTube, kindly make sure you also put into the chat box where you're from. Excellent. Nice seeing everybody. We'll get started in just a few minutes. All right. Just a real quick audio check. If you all can hear me, see my slides, and also see my video, can you just type in yes into the chat box? All right. Wonderful. I know I'm a little bit animated today when it comes to the holidays, but I appreciate all of you who are celebrating the holidays and have taken some time after or during your break to join me today. So thank you so much for the feedback. Many people are saying they like the hat. I appreciate it. All right, wonderful. Well, let's go ahead and get started. I am so glad you all are here today. Happy holidays. And today is going to be a very special webinar because what we're going to be doing is going through the key vignette triads that you're going to see on step 1 and step 2 CK. If this is the first time you are attending one of my webinars, I welcome you. If this is your 100th webinar, welcome back. My name is Rahul. I'm a practicing pediatric critical care physician. I'm also very passionate about medical education, particularly helping students prepare for and excel on step 1 and step 2 CK. I hope that that glimpse of passion will come right through to your study space today over the next hour. So I am excited to get started today. I know there are so many resources out there, but I want to just share what makes my baby HyGuru so unique. When it comes to HyGuru, I think it is one of the most active recall resources when it comes to studying medicine and USMLE preparation. Each of my lectures are rooted in active recall, which is documented in the literature to be a high yield strategy when it comes to learning content in medicine. Secondarily, what I like to do is I like to draw connections between different concepts. And then finally, one of my favorite passions here is to have you and empower you to think like the test maker. And that is where you and I, during these sessions, break down the vignettes and have the lens. How are these triads actually tested? Speaking of triads, when it comes to the triad that I use to help prepare students, I focus on integrating content and test-taking strategy, making sure that students are productive, even small things like reviewing a UWorld block most effectively. These are things that I really value when it comes to USMLE preparation. And finally, as you can see, my energy today, I hope you share in the same energy. I focus on making sure you have a growth mindset and positive test-taking psychology so you can perform on Prometric exam day. This may be a depiction of some of your medical school lectures, even some video resources. But when it comes to HyGuru, you will notice that there is deliberate integration. We are going to be jumping from topic to topic, making sure not to confuse you, but actually keeping it very dynamic. Think of it like a gym session where you are going through the overall journey and story and also reviewing both questions and content at the same time. When it comes to HyGuru, I have been extremely blessed to have students just like you support me each and every step of the way. And what I try to do is I like to take all of the salient resources from a question standpoint and a content standpoint, and I like to focus on the most frequently assessed topics. One of the things I'm very passionate about is making sure that you, as a student, can have consistency around the highest yield topics. How are they asked, and making sure you understand within a disease, what are the specific questions that test makers go for. Today is quite a showing, and I am so excited to let each of you know that you all inspire me. And over the last 7 years, ever since I was a fourth-year medical student, HyGuru has grown to become a family. These are some pictures from when I was teaching live in classrooms, and now I am teaching you online today. It is quite the global community of lifelong learners, and I'm super excited that you all are here today. At the end, I'm going to be going through some new announcements, some course additions to my Step 1 course, my test-taking strategies course, as well as my Step 2 CK course. But without further ado, I want to make sure we get to the content and why you all are here today, and that is going through the key vignette triads. So if you are ready for this holiday review, go ahead and type in yes into the chat box. Is everybody ready to go? All right, wonderful. This hat got a little warm and uncomfortable, so I'm going to take it off for a little bit, but I'll put it back on at the end. All right, very nice. Joy, Vivian, Jayati, excellent. Well, thank you all so much for joining. Many of you may not be familiar about what a triad in medicine is. And so what I wanted to first do is give you the definition of what a triad is in medicine. I actually looked this up in Wikipedia, and Wikipedia defines a triad as a group of 3 or more signs or symptoms. And when they come together, they are going to characterize a specific medical condition or diagnosis. Usually these triads are going to affect many different organ systems. And so our goal today is to really hone in on how to recognize triads and how to apply triads. And I want you to really keep that in mind. The USMLE loves to go for triads. In fact, they're going to give you vignettes where they put key components of the triads and expect you to recognize that and then subsequently apply it. So understanding triads, you probably do this when you're smashing the space bar in Anki or just going through some single order questions. Many of you have seen this triad in first aid, for example, hypercoagulability, stasis, endothelial injury. Go ahead and type that into the chat. What kind of triad is this? Okay. Many of you are saying Virchow's triad. Yep, exactly. Dr. Virchow's triad. But in my opinion, I don't think that this is enough, because the USMLE really wants you to paraphrase the various data points. In fact, this same triad is tested on the USMLE by making you recognize that hypercoagulable state. Maybe they put an underlying oncological process. Maybe the female is on oral contraceptives. Maybe for endothelial injury, they talk about placement of a central venous catheter that caused the venous injury. Or they say something like sepsis and cytokine injury. Or they give you a patient with AFib, and they want you to recognize that AFib or a prolonged truck ride or an airplane ride is going to be related to stasis. So all of these triads are going to be displayed in a vignette in a very unique way. And our goal today is to apply the content from the triads. So today is all about content integration and application. What we'll do is we'll introduce the triad. We'll go through the key vignette characteristics. I'm going to be putting step 2CK type questions in here as well and incorporate pharmacology. And I have written many NBME style questions for us to practice. All right, here we go. Let's go ahead and go through our first question of today. Here we go. A 50-year-old man with history of chronic alcoholism presents with acute onset of confusion. He has no history of chest pain or trauma. On examination, his blood pressure is low at 85/60. He is tachycardic at 110 beats per minute, and neck veins are distended. Cardiac auscultation reveals distant heart sounds. Lungs are clear to auscultation. Which of the following best describes the pathophysiologic mechanism underlying this patient's presentation? A, cardiac tamponade. B, congestive heart failure. C, ruptured aortic aneurysm. D, tension pneumothorax. Or E, acute pericarditis. What do you all think is the triad here? Excellent. If you are saying A, cardiac tamponade, you are absolutely correct. Remember, cardiac tamponade is going to be fluid surrounding the heart. Now, when you are going to have distended neck veins, you want to understand that the central venous pressure is going to be very high. Now, out of all these answer choices, tension pneumothorax also is going to have an elevated central venous pressure. So how do you tell the difference? Well, in tension pneumothorax, the lungs would have asymmetric auscultation, i.e. on a unilateral side, there would be decreased breath sounds and hyperresonance. So when it comes to a patient who is going to have signs of fluid overload, say, for example, they have an underlying cancer, say they have radiation to the chest, maybe they are going to have lupus that has a lot of serosal inflammation. Think about how you can get fluid surrounding the heart. Even recurrent pericarditis can give you this. And the triad is going to be hypotension, JVD, and distant heart sounds. So let's go ahead and go through the clinical triad known as Beck's triad for cardiac tamponade. First is hypotension. In the vignette, what you want to recognize is that patients may have pulsus paradoxus, which is going to be an abrupt decrease in your systolic blood pressure on inspiration by 10 millimeters of mercury. They may have a narrow pulse pressure, which means the systolic and diastolic numbers in the vignette vital signs are going to be narrow. And what you want to know is that the hypotension is due to the fluid compressing the non-muscular right ventricle. In diastole, remember that the right ventricle is going to relax, and the right ventricle has less muscle compared to the left ventricle. And that's why RV collapse in diastole is one of the echocardiographic findings of cardiac tamponade. Now, because you have this RV collapse, you are going to have RA collapse because of excess amount of fluid, and that's going to increase your central venous pressures, and that's why you have jugular venous distension. Recall, just like a tension pneumothorax, cardiac tamponade can give you a high amount of intrathoracic pressure. You're also going to get distant heart sounds, and the physics on this is that you have decreased transmission of sound waves because now you are going to be auscultating through a fluid medium. The next best step in management is going to be a pericardiocentesis. Okay, and typically that's going to be a subxiphoid approach. All right, let's go ahead and go through this triad. I want you to type in the answer into the chat box. The triad of pulsatile mass, hypotension, and flank pain. This is a hard one. What do you think this is? Excellent. Many of you are putting abdominal aortic aneurysm rupture. You're absolutely correct. Let's go ahead and break down the triad. As you can see, what I'm doing is I'm giving you the triad, and I'm going to be giving you the vignette characteristics as well as just a little bit of a pathophysiologic explanation as to how this is happening. So let's go ahead and go through the abdominal aortic aneurysm rupture triad. The pulsatile mass, remember in your social history, the patient is going to be a smoker. Also recognize that they could have atherosclerotic risk factors, diabetes, hypertension, dyslipidemia in the past medical history. This is going to weaken the arterial layers, and thus you are going to get a pulsatile abdominal mass. Maybe they will say an abdominal bruit as well. In a ruptured AAA, there is going to be a massive blood loss. These patients are going to have hemorrhagic shock. Remember that from a cardiac standpoint is going to reduce your preload. And if you reduce your preload, your stroke volume is reduced, and thus you are going to get less cardiac output. Patients who are going to have a AAA may have flank pain, and this represents bleeding into the retroperitoneal space. Recall the aorta, just like the kidneys, are going to be retroperitoneal structures. All right, with that, let's go ahead and go through our next question. But I just want to check in with you all. Are you all learning something? I know we just got started. All right, Ahmad is, Manmeet, Princess, Jacqueline. Excellent. I just want to pause right here and just let you all know that my goal is to give you a very succinct review. I ask you to just turn off all notifications, make sure you are removing distractions so you can stay active and engaged and learn the most from this webinar. All right, here we go. Let's go through this question. 72-year-old man, history of hypertension, presents with subacute shortness of breath, which worsens while gardening. He has occasional chest pain, and he was recently admitted for episodes of, quote, passing out. He reports that these symptoms have progressively increased over the past year. On exam, he is hypertensive to 130/70 and has a heart rate that's normal at 78. Cardiac auscultation notes a murmur and a paradoxically split S2 heart sound. What is the likely diagnosis? A, aortic regurg, B, aortic stenosis, C, pulmonary regurg, or D, mitral stenosis? Excellent. Very good. Many of you are going to say B, aortic stenosis. You're absolutely correct. Recall that the triad is going to be dyspnea, which is an exertional dyspnea because the aortic valve is going to be stenotic. You can't get blood out. Syncope and angina. Okay, so this is the triad that is going to be present. We're going to be talking in the next slide about the paradoxical S2 heart sound. Recall that aortic stenosis typically is going to be a calcific stenosis that is going to be due to wear and tear, especially in the elderly population. However, if you are going to get a middle-aged patient that is going to have aortic stenosis, think about underlying bicuspid aortic valve. And the other question that the USMLE likes to go for is that Turner syndrome is linked to bicuspid aortic valve. Very good. All right, so we're going to be going through aortic stenosis. We talked about the triad SAD, syncope, angina, and dyspnea. Let's go through the vignette characteristics. So syncope, they'll put fainting on activity. This is because the aortic valve is so stenotic, you can't get blood from left ventricle into the aorta. As a result, your cardiac output is going to be impaired and you are going to have decreased cerebral perfusion. If you can't get blood flow to the brain, you're going to have syncope. Angina is going to come because the patient with aortic stenosis is going to have a high afterload state. Recall that the afterload is going to increase your myocardial oxygen consumption. If you have high myocardial oxygen consumption, that is going to be greater than the coronary supply, you are going to get angina. And this in a vignette presents with chest pain on exertional activity. Patients also are going to have shortness of breath in aortic stenosis, and this is just due to the fact that they have decreased left ventricular performance. Now, patients with aortic stenosis, because the aortic valve is so narrow and stiff, you are going to have a paradoxical S2. And let's just review this from a normal physiology standpoint. So normally during inspiration, you are going to have the closure of the aortic valve prior to the pulmonic valve. So aortic valve is going to close first, and then you are going to have the pulmonic valve close. And that's just because when you inspire, you get increased preload to the right ventricle, and you need just a little bit more time normally for the pulmonary vasculature to fill. However, in aortic stenosis, you are going to get a paradoxical split. And this is going to be where the aortic valve is actually going to close after the pulmonic valve, specifically on exhalation. What you're going to note here is that the paradoxical S2 is going to be due to any sort of pathology that is going to reduce left ventricle pumping out to the systemic circulation. Aortic stenosis, hey, you are not going to have LV go into the aorta. A left bundle branch block, again, the electrical activity is going to be impaired. So the mechanical activity of the left ventricle is also going to get impaired, and thus you can't pump forward. So recall that paradoxical S2 is going to be in aortic stenosis. All right, very good. Let's go ahead and go through this active recall question. This is a different type of vignette that I've placed in the webinar today. So a 24-year-old woman presents with acute unresponsiveness after a stab wound to the chest. Vitals are notable for hypothermia, hypotension, and tachycardia. The patient is resuscitated in the trauma bay with multiple packed red blood cell transfusions. On lab assessment, post-resuscitation, the patient has a coagulopathy with an elevated PT and PTT. What is the likely mechanism here? So in this situation, the patient is going to have hemorrhagic shock. The patient had a stab wound, and here is a very important test-taking tip for step 1 and step 2. Whenever you see hypotension and tachycardia, just say the S word, and the S word is going to be shock. When I'm on call in the pediatric ICU and I see hypotension, tachycardia, I'm saying a different S word. You can extrapolate there. But recall that in hemorrhagic shock, you are going to get a lot of blood transfusions. Now, in the ideal scenario, you may get a balanced red blood cell or balanced blood product transfusion where you are going to give 1-to-1 red blood cells, fresh frozen plasma, platelets, and cryo. However, this triad is going to be very important for us to know, and that is going to be the triad of trauma. Now, the triad for trauma is going to be coagulopathy, hypothermia, and metabolic acidosis. So in resuscitation, when you are going to give too many PRBCs, you can get dilution of the coagulation factors that are going to then give you the elevated PT-PTT. Hypothermia is also going to cause you to have disruption of secondary hemostasis, and you're not going to have good clotting factors. So just to review the trauma triad, you're going to be thinking of coagulopathy, metabolic acidosis, and hypothermia. So when you have a coagulopathy that's due to the transfusion, that coagulopathy is going to mess with biochemical pathways like aerobic metabolism. So the coagulopathy can actually induce a lactic acidosis. That lactic acidosis can give you an anion gap metabolic acidosis. And when you have a acidosis in the body, you're going to have decreased myocardial performance. Well, if you have decreased myocardial performance, you can't get the blood to the extremities. And as a result, your extremities are going to be cool and your core body temperature may also drop. And that's why you get hypothermia. And this creates this vicious cycle because hypothermia then is going to halt the coagulation cascade and worsen your coagulopathy. All right, here is going to be the next triad. A patient with asthma undergoes nasal endoscopy and you see this fluctuant mass. What do you think is the likely triad that I'm going for here? Excellent. This is going to be a triad of asthma, nasal polyps, which is going to be seen on nasal endoscopy, and characteristically, what medication are these patients going to have a little bit of intolerance to? That is going to be aspirin. So remember that aspirin is going to be a COX inhibitor. Aspirin is going to irreversibly bind cyclooxygenase and thus decrease prostaglandins. But patients who are going to have aspirin intolerant asthma are going to not only inhibit cyclooxygenase, but then have the arachidonic acid shift to the lipooxygenase pathway, and this is where you're going to get increased amounts of LTB4, which is going to bring in neutrophils, and LTD4 and E4, which are going to cause you to have bronchoconstriction. And what they'll put in the vignette is they got aspirin, maybe they have some coronary artery disease, etc. And then on physical exam, they will have wheezing. And that's how you recognize that there is lower airway obstruction. Okay. So asthma, nasal polyps, and aspirin intolerance. All right. Let's go ahead and go through this question. This is an arrow question, very high yield type of question. An 18-month-old boy presents with chronic failure to thrive and polyuria, so increased urination. The patient has failure to thrive, dropped from 50th to the 8th percentile. Urine analysis shows glucoseuria with normal serum glucose levels. That ruled out diabetes mellitus. Serum tests show hypophosphatemia, hypokalemia, and a normal anion gap metabolic acidosis. Which of the following nephron locations and pathophysiologic mechanisms underlies the diagnosis? You're going to be looking at the nephron location and also the function that is going to be messed up. What do you think is the best answer here? Excellent. So many of you are localizing this pathology to the proximal convoluted tubule, and you're absolutely correct, because remember, proximal convoluted tubule, that is going to be reabsorbing majority of your solutes and electrolytes. You're going to have reabsorption of things like cysteine, ornithine, leucine, arginine. You're also going to be having reabsorption of a lot of your phos as well as potassium. What you're also going to have a lot of reabsorption of is bicarbonate. And so this patient is going to have Fanconi syndrome. And Fanconi syndrome is going to be sometimes a genetic defect. And whenever you see failure to thrive, you should be thinking, hey, is this patient going to have some underlying immunodeficiency or some underlying genetic abnormality? Now, when it comes to Fanconi syndrome, recognize that when you waste bicarb into the pee, that is technically going to be a proximal type 2 renal tubular acidosis. And the USMLE loves for you to know that a proximal renal tubular acidosis is going to be conceptualized with Fanconi syndrome. Another farm tie-in that can do the same thing, make you waste a lot of bicarb, acetazolamide, a carbonic anhydrase inhibitor. Now, I've heard of Fanconi in other pathologies, and this is exactly how I learned when I was going through the USMLE process. If I recognize, hey, there should be some other Fanconi, I just Venn diagram them and put them together. So we talked about Fanconi syndrome. This is a loss of proximal convoluted tubule function. You're going to have increased excretion of amino acids, glucose, as well as bicarbonate, and you're going to have a proximal type 2 RTA. Now, something very different is going to be Fanconi anemia. This is where you're going to have a loss of DNA cross-linking. So if you can't repair DNA effectively, you're going to have skin lesions like cafe au lait spots. Remember, you see cafe au lait spots also in neurofibromatosis. You can also have thumb and radial defects. This is kind of the hallmark sign on physical exam, or they can give you a hand x-ray that shows the absent radius or two thumbs. Patients can get aplastic anemia because you messed up DNA, and you can also be predisposed if you don't have good DNA cross-linking or repair mechanisms to acute myelogenous leukemia. So understand the difference between Fanconi syndrome and Fanconi anemia. All right, let's go ahead and go through this NBME style vignette. I want you all to put in to the chat box, what's the diagnosis? Let me read you the vignette. A 35-year-old woman presents with chronic history of persistent urinary dribbling post-voiding. She has recurrent episodes of dysuria and dyspareunia, which is pain during intercourse. Physical exam is notable for tenderness on the anterior vaginal wall to palpation, and a small amount of urine is expressed from the urethra when pressure is applied to this anterior vaginal wall. What is the likely diagnosis in this situation? Going to give you some time to think. Excellent. If you all are going to be saying urethral diverticulum, you're absolutely correct. So what is a urethral diverticulum? It's an outpouching of the urethra. And we're going to see a picture of this in the next slide. But recognize that a urethral diverticulum presents with the triad of dribbling, dysuria, and dyspareunia. As you can see, here is going to be the bladder. Here is going to be the urethra. And you can see a diverticulum is just an outpouching of the urethra, such that when you are going to manipulate the anterior vaginal wall via palpation, it's going to hurt because it's inflamed, but you can also expulse a little bit of urine as the urine is collected in this reservoir. Let's go ahead and switch to a multiple choice question. A 53-year-old male presents with chronic abdominal discomfort. The patient states he first noticed pain on his right flank several months ago, and it has gradually been getting worse. So this is progressive chronic abdominal discomfort. For the past week, he's also noticed blood in his urine. The patient denies any fever, chills, or dysuria. He has a 40-pack year smoking. He also has hypertension. Physical exam is unremarkable. CBC reveals a very elevated hematocrit and a urine analysis positive for red blood cells and negative for leukocytes. So please note that if you see negative for leukocytes and you notice no dysuria, fevers, or chills, you have ruled out a urinary tract infection, and that's high yield for us to know. Which of the following is going to be the most likely diagnosis? A, bladder cancer, B, a kidney stone, C, pyelonephritis, D, renal cyst, or E, renal cell carcinoma? And I want everybody to answer. Please take the time, stay active and engaged. Excellent. If you're saying renal cell carcinoma, you are absolutely correct. Now, I want you all to really recognize here that tempo matters a lot. Whenever you see a chronic tempo, you should be thinking more about neoplasia. When you see acute tempo, let's say that the pathology in your history of present illness is occurring less than 2 weeks, you should be thinking of infection, inflammation, trauma, or some sort of obstruction, like a pulmonary embolism or pneumothorax or something. Okay. So in this case, hematuria that is painful in a smoker, you're going to be thinking of renal cell carcinoma. Let's go ahead and go through the triad of renal cell carcinoma. Recall that we talked in the vignette of unilateral abdominal pain, a urine analysis that's going to be positive for red blood cells, and you may at times see a flank mass on physical exam. Now, why do you get the flank pain? Well, it is because the renal cell carcinoma is going to stretch the renal capsule. Why do you get the hematuria? Because this represents the tumor invading into the renal pelvis, and thus you are going to have red blood cells now go from the renal pelvis down the ureter and into the urethra. And why do you get polycythemia? Well, polycythemia is going to be due to a paraneoplastic erythropoietin secretion. Recall that erythropoietin, just as an endothioin, acts via JAK-STAT pathway, and you are going to get the bone marrow then to increase red blood cells. And when you increase your red blood cell mass, you are going to have elevations in your hematocrit. All right, here is going to be another triad that I want you to recognize. All right, here we go. Which is the diagnosis if I say can't see, can't pee, can't hear high C? What do you think is the diagnosis here? All right. Very good. A lot of different answers. Can't see, can't pee, can't hear, high C. That is going to be Alport syndrome. Now, Alport syndrome is going to be an issue where you're not going to have good basement membrane. Your type 4 collagen is going to be messed up. As a result, the eye as well as the ears are going to be affected. You also are going to have a nephritic issue in your glomerulus. So can't see. These patients are going to have retinopathy. These patients can also have an elevation of the lens known as anterior lenticonus. And this is, again, because of bad collagen. Can't pee. Typically in the vignette, they may say history of hematuria. Remember that this is going to be X-linked, so it could be in males. Remember that if you have a glomerulonephritis, you're going to see casts that are red blood cell casts on the urine analysis. Now, can't hear, high C. This is going to be where you're going to get sensorineural hearing loss. And this is particularly going to be for the higher tones. Recall that histologically in your ear, you are going to have the cochlea have a specialized cell area known as the organ of Corti. Bad type 4 collagen, bad basement membrane of the organ of Corti, you are going to have decreased integrity of this organ, and you're going to have less sound transmission to cranial nerve number 8. So key things for us to recognize for Alport syndrome. I like to say Alport, so I know that that is going to be type 4 collagen. You can get abnormal glomerular basement membrane. That is going to lead to the nephritic syndrome. And as you can see, the organ of Corti is going to be this whole structure. And if you are going to have bad basement membrane, you won't be able to transmit the sound. And that's why you get sensorineural deafness. So many of you were talking or putting in the chat box, not only can't see, can't pee, can't hear, high C, but the other triad, which is of reactive arthritis. So let's go ahead and compare and contrast that. Alport syndrome is can't see, can't pee, can't hear, high C. Whereas reactive arthritis is going to be can't see, can't pee, so similar to Alport. However, it's can't climb a tree, indicating that patients with reactive arthritis are going to have issues with the joints. Let's go ahead and go through how does reactive arthritis as a triad present on the USMLE. Before I continue, are you guys staying active and engaged? Is everybody doing okay? All right. Excellent. This is awesome. Everybody, you are all part of, right now, over 300 people joining. This is absolutely phenomenal, and I'm so grateful you're here. All right. So reactive arthritis in a vignette, irritated erythematous eyes is what you're going to be seeing in your physical exam. The patient in your history may actually endorse dysuria. They may also have this symmetric joint pain. So let's map this to the triad. Can't see. Well, in reactive arthritis, recall that this is going to be a rheumatoid factor negative, HLA B27 positive, seronegative spondyloarthropathy that can be triggered by chlamydia or Shigella or even E. coli. Now, the can't see represents conjunctivitis, and this is due to the antigenic inflammatory response. Another thing for us to note is that the patients can have urethritis. Now, this urethritis is going to be due to the fact that if you have a genitourinary trigger like chlamydia or a GI trigger like Shigella, that can cause mucosal inflammation of the urethra, and you can get urethritis. And then can't climb a tree actually has to do with molecular mimicry, where you're going to have cross-reactivity between bacterial antigens, say, of Shigella, as well as self-antigens. And recall that molecular mimicry is also going to be one of the driving mechanisms in rheumatic fever. So reactive arthritis, can't see, can't pee, can't climb a tree. All right, what about this triad? Relapsing uveitis, recurring genital ulcers, and also recurring oral ulcers, also known as recurring aphthous ulcers. What do you think is the triad here? Go ahead and put that into the chat. Excellent. Many of you are saying Bechet syndrome. And if you're saying Bechet, you're absolutely correct. This is going to be a patient who is going to have anterior uveitis. They're going to have recurring genital ulcers that can scar, and they also are going to have aphthous ulcers. Now, aphthous ulcers are going to be also seen in Crohn's disease, as well as in lupus. So these are some differentials to keep in mind when you see these recurring oral ulcers. So let's go ahead and apply this disease. Here we go. A 28-year-old man comes to the physician for chronic recurrent oral ulcers. During this period, he has had 2 painful genital ulcers. He's also had joint pain, malaise, and low-grade fever. He is sexually active with 1 female partner, and they do not use condoms. He takes no medications. Physical exam shows 3 painful ulcers on the oral buccal mucosa. Pelvic examination shows that the external genitalia has several healing scars. The immunological mechanism most likely responsible for this patient's condition involves dysregulation of which of the following cells? B cells, T cells, neutrophils, or complement. What do you think is the best answer here? Excellent. If you are saying T cells, you're absolutely correct. Bechet's disease is usually thought to be due to abnormal T cell function. Remember that in Bechet's disease, you have this very unique T cell response known as pathergy. And pathergy is going to be an exaggerated response of the immune system to just minor trauma. And the antonym for pathergy is actually anergy. Anergy refers to when you don't have an immune system or when you don't have good T cells and a lack of an immune response. All right, let's pivot into histology a little bit. What is the triad? Where you have bile duct, hepatic artery, as you can see, red blood cells are in here, as well as the portal venule. That is going to be the portal triad. You're absolutely correct. You know, one thing I want to highlight in this picture is this right here. Remember that arteries and arterioles are going to have a thick tunica media. This is so important. When I am in the pediatric ICU and I'm putting in central lines, I apply this concept at the bedside all the time. Why is that? Because if I have the ultrasound probe and I am going to be looking at blood vessels, if I see a blood vessel that is going to be easily compressible, I know that that is going to be a vein. So veins are on ultrasound are easily compressible, and it relates to the histology tie-in that arteries are going to have a thick tunica media, so they're not going to be as compressible. All right. So when it comes to the portal triad, we need to incorporate the USMLE questions related to zone 1, zone 2, and zone 3, necrosis and pathology. As you can see, this is the portal triad, and this is going to be the hepatic vein. Recall that in the portal triad, there you are going to have the portal vein. Now, as you can see, zone 1, this is where you're going to have a high amount of oxygen because the artery is going to be right here. Whereas zone 3, this is the one that is going to be most susceptible to ischemia because, as you can see, you are going to have less blood flow to this last area. So the zone 1 necrosis questions are all going to be related to any ingested toxin, like cocaine, for example, can cause you to have vasoconstriction of the arteries and zone 1 necrosis. It's also going to be the one that is going to be affected by the viral hepatitis agents. For example, hepatitis B, which is a DNA virus, is going to affect this portal triad zone 1. Zone 2, that is going to be related to yellow fever. I just like to put 2 parallel lines, yellow, Roman numeral 2. And then zone 3, this is going to be the central lobular zone. This is going to be nearest to the hepatic vein. We already talked about how it's most susceptible to ischemia, but also recognize that this is where you have the highest concentration of CYP enzyme. So this is going to be most sensitive to metabolic toxins, in particular, toxins that need CYP. So for example, ethanol, acetaminophen, rifampin. These are processed by the CYP enzymes, and the most highest quantity of CYP enzymes are going to be in the zone 3. Now recognize that ethanol, you are going to have in your labs AST slightly greater than ALT. Acetaminophen, remember, that is going to increase the amount of NAPQI, which is going to be a free radical intermediate. Remember, the farm tie-in is N-acetylcysteine, is going to make your NAPQI more excretable. And then rifampin, which is going to be part of tuberculosis therapy. All right, let's go ahead and go through this question. One of the ways that I continue to stay active and engaged whenever I am going through question blocks is I say every single question, and this got me through exam day as well. Every single question is a patient, and I have the ability to take the knowledge that I have and apply it to these vignettes as if I'm going to be seeing patients. So let's see this patient together. Here we go. A 45-year-old man with history of paroxysmal nocturnal hemoglobinuria presents with abdominal pain, scleral icterus, and physical exam notable for prominent liver edge. On Doppler ultrasound, there is decreased flow in the IVC. What is the likely diagnosis here? Excellent. Lack of flow in the IVC in a patient who has an underlying hypercoagulable state. You're absolutely correct. That is going to be Chiari syndrome. The triad here is abdominal pain, ascites, and hepatomegaly. And recall, it's because if the IVC is messed up, you are going to have liver congestion, and that then is going to present in your vignette as hepatomegaly in the physical exam. Now, causes of Chiari syndrome, you want to be thinking of your Virchow's triad, because essentially you're obstructing the IVC. You're obstructing the hepatic drainage. So things like hypercoagulable states like polycythemia vera, where your blood is like ketchup and you have increased viscosity. If you have increased viscosity, you have increased resistance to flow. You also have endothelial injury, and that can cause you to have thrombosis in the caval system. Postpartum state, again, high estrogen states can cause you to be hypercoagulable, as well as underlying hepatocellular carcinoma. Again, it all relates to Virchow's triad. I want to contrast Chiari syndrome from portal vein thrombosis. Recall histologically or from an anatomy standpoint that the portal vein is going to drain the gut, and then you are going to have, via the hepatic vein, the caval circulation. Now, if you have a portal vein thrombosis, one of the physical exam features that you will not see is hepatomegaly. So patients who have portal vein thrombosis do not have hepatomegaly. Portal vein thrombosis, you can get signs of portal hypertension, i.e., if you obstruct the portal vein, it's as if you have like a cirrhotic liver. You can get things like esophageal varices or splenic varices. You can also get this congestive bowel ischemia because now you don't have any venous drainage of the hepatic arterial blood. Triggers for portal vein thrombosis, you can be thinking of cirrhosis, colon cancer, as well as pancreatitis. One of the classic CT scans that you are going to see when it comes to colon cancer metastasizing to the liver is multifocal lesions on abdominal CT. And the USMLE loves for you to know that whenever you are going to be thinking of metastasis, which is, again, from chapters 1 through 3 of pathoma, relates to neoplasia, specifically relates to staging, the TNM staging, tumor node metastasis staging. multifocal lesions on gross and radiographic pathology, very high yield for us to know. Now, the differential diagnosis of nutmeg liver is also going to be high yield for us to know. Nutmeg, I mean, it's just like Christmas right now. So nutmeg liver is just basically congestion of the liver, okay? So this congestion of the liver is going to be due to, number one, Budd-Chiari syndrome, which is going to be an obstruction of the IVC, or if you are going to have the right ventricle back up into the RA and all that blood is going to back up into the liver, causing a congestion, and that's known as nutmeg liver. All right, we're going to go through a very unique triad, but this triad I'm going to be giving to you in sequential pathophysiology steps. Let's continue to stay active and engaged. We're almost done with today's webinar. All right, you have biliary tree obstruction. That then leads to stasis within the bile ducts. And then you get a superimposed bacterial overgrowth and infection. What is this diagnosis? Go ahead and put it into the chat. What is this diagnosis? Excellent. If you're saying ascending cholangitis, you're absolutely correct, also known as acute cholangitis. And we are going to review the triad in just a second, but this is how I teach for Step 2 CK. You'll see this a lot in my Step 2 CK course, and that is incorporating the farm right next to the pathophysiology. Remember that the bacterial overgrowth, typically it's going to be with E. coli as well as Pseudomonas microbes. You're also going to have anaerobes that are going to infect the bile duct tree. So gram-negative coverage, you want to think of ceftriaxone, piperacillin tazobactam, fluoroquinolones. Okay. And what are you going to use for the anaerobic coverage? Probably metronidazole, which is also known as Flagyl. Okay. And that's for anaerobic coverage. Remember that when you have infection of the biliary tree, that is close proximity to the liver. So one of the most common causes of multifocal liver abscesses, not only are you going to be thinking of Entamoeba histolytica, but you're also going to be thinking of ascending cholangitis that can cause multiple liver abscesses. Remember, liver abscesses are going to present with fever plus right upper quadrant pain. You can also have shortness of breath because the USMLE wants you to know that the diaphragm can get irritated. This will be unresponsive to antibiotic therapy. And the USMLE wants you to know that an abscess is going to be a histologically bound simple epithelium where antibiotics are not going to be able to penetrate. And that's why they say unresponsive to antibiotics or persistent fevers or inflammatory markers. And then for Step 2 CK, they want you to know that ultrasound is going to show air fluid levels, and the next best step in management is going to be drainage of the abscess because that gives you source control. So ascending cholangitis, this is one where you go from triad to pentad, which is 5 things. Can you name one portion of the pentad of ascending cholangitis? Go ahead and type this into the chat. One component of the pentad of ascending cholangitis. So I'm seeing hypotension. Excellent. Can I get others? Altered mental status. Wonderful. Shock state. Excellent. Very nice. So remember that ascending cholangitis, also known as acute cholangitis, it's different than primary sclerosing cholangitis. Primary sclerosing cholangitis is going to be the onion skinning. So ascending cholangitis is the infection of the biliary tree. Okay. So the mechanism here is you get obstruction of the biliary tree that leads to stasis and then bacterial overgrowth. The triad of ascending cholangitis is jaundice, right upper quadrant pain, and fever. Jaundice on your USMLE can present on physical exam as scleral icterus, or in labs, it can present as increase in total bilirubin. Remember to think like the test maker when it comes to recognizing triads, specifically even ascending cholangitis. Increased bilirubin, physical exam showing tenderness in the right upper quadrant. In the vital signs, they'll put a temperature greater than 38 degrees centigrade. And then what do we do to make the triad of fever, right upper quadrant pain, and jaundice a pentad? You add altered mental status or shock type state, i.e. hypotension. And again, that will be seen in the vital signs. So overall, when I'm going through how to recognize some of these concepts, it's not just about the content itself. I also try to figure out where in the vignette are these data points going to be embedded, and how do I interpret them effectively? So once I interpret them effectively, the content then gets activated and I can come to the correct answer. Another triad to pentad, hemolytic uremic syndrome. Let's do the same exercise. Name one component of the triad of hemolytic uremic syndrome. Go ahead and type that into the chat. One component of the triad of hemolytic uremic syndrome. Excellent. So this pathology actually is going to have the triad embedded into the diagnosis. You get microangiopathic hemolytic anemia, you get uremia, so acute kidney injury. And the reason why you have this hemolytic anemia is because of platelet consumption in the microvasculature. And when you get platelet consumption, you get thrombocytopenia, very high yield for us to know. So let's go through the pathophysiologic mechanism. This is going to be a couple steps, but I want you to just hone in, stay active, and engage with me. So typically, when it comes to HUS, you are going to have E. coli 015787 that is going to secrete the Shiga-like toxin. The USMLE wants you to know that the Shiga-like toxin inactivates 6DS subunit of ribosomes, and that then is going to cause cytokine release. Now, when you have cytokine release, you're going to damage vascular endothelium. Well, I'm smelling a Dr. Virchow now. Absolutely. The damage of the vascular endothelium is going to induce endothelial injury and subsequent microthrombi formation. Once you have microthrombi formation in the microvasculature, you're going to have essentially speed bumps. And these speed bumps are going to consume platelets, and that's why you get the thrombocytopenia. As the red blood cells are going to be going over the speed bumps, you get intravascular mechanical shearing, and you can get the helmet cells known as schistocytes. Now, what kind of anemia are you going to get in your exam question? You're going to get a normocytic anemia, and that's exceedingly high yield for us to know that many normocytic anemias, where your MCV is 80 to 100, you are going to characterize and conceptualize those as hemolytic anemias. Finally, if all of the vasculature that is affected is, let's say, in the glomerular tuft or the afferent arteriole, you are going to have reduced renal blood flow, and that is how you can get the uremia, i.e. this is going to be a intrinsic acute kidney injury where your BUN to creatinine ratio is 10 to 15 is to 1. So the triad, microangiopathic hemolytic anemia, thrombocytopenia, and acute renal failure. And how do you make the pentad? That is going to be adding fever and altered mental status. Now, what is high yield for us to know is TTP and HUS are going to be on a spectrum, i.e. hemolytic uremic syndrome and thrombotic thrombocytopenic purpura. They're both going to be on a spectrum. So let's understand TTP a little bit more. A patient is admitted in the ICU. He has high LDH, low hemoglobin, so anemia, and low haptoglobin. CBC shows thrombocytopenia with coagulation factors that are going to be low, and the PT-PTT is going to be normal. And I apologize, the coagulation factors in this pathology are normal. So both coagulation factors and PT-PTT are going to be normal, but the platelets are going to be low. He has increased creatinine on his lab exam, and when you examine him, he has altered mental status and a temperature of 102. His peripheral blood smear shows schistocyte. So let's first map out the HUS triad. So anemia, the patient has that, check. And with the low haptoglobin, you want to recognize that this anemia is going to be what kind of anemia? It is going to be an intravascular hemolysis that is leading to anemia. Because recall that if you have red blood cells shear within the blood vessels, they release free heme. And if you have too much free heme release, that consumes your haptoglobin. So your haptoglobin is going to be low. Thrombocytopenia, absolutely. Remember that this is going to affect only primary hemostasis, not secondary. So you are going to have a normal coag profile. And then anemia, thrombocytopenia, and acute renal failure, you see that with the increased creatinine. But then you have fever and altered mental status. And the mechanism here is going to be low Adams TS13. Now, remember, Adams TS13 is going to be very high yield on NBME questions, a matrix metalloprotease. And typically, Adams TS13 normally is going to cleave von Willebrand factor. If you are going to have TTP, you have decreased Adams TS13, and as a result, you have large von Willebrand multimers, and this is what's going to perpetuate your microvascular disease. So Adams TS13 is a matrix metalloprotease, which normally cleaves von Willebrand factor. TTP is going to affect primary hemostasis, and that is why the PT, PTT are going to be normal, because those are going to be secondary hemostasis related. Interestingly, Shiga-like toxin produces factor that decreases Adams TS13. This is the acquired form of thrombotic thrombocytopenic purpura, i.e. a continuation of Shiga toxin mediated hemolytic uremic syndrome. Treatment is going to be plasma exchange. This is high yield for step 2 CK. Why is that? Because the USMLE wants you to know that when you exchange the plasma, you take out the big von Willebrand multimers and you give back smaller cleaved von Willebrand multimers as well as Adams TS13. So what plasma exchange does is it inhibits the nasty plasma that is ridden with antibodies, and you replace normal plasma. All right, let's go ahead and go into this question. A 55-year-old man is admitted to the ICU following a severe traumatic brain injury. He is intubated and sedated. His current vital signs show very severe hypertension, heartbeat of 55 beats per minute, and significant ventilator patient dysynchrony. Neurological exam reveals a left-sided dilated pupil, so an unequal pupil that is slow to react to light. Which of the following is the most appropriate initial management for this patient's cerebral edema? A, administer hypotonic solution. B, administration of crystalloid isotonic solution. C, administer hypertonic saline. Or D, reduce sedation. What do you think is the best answer here? Excellent. If you're saying 3% hypertonic saline to reduce intracranial pressure, you're absolutely correct. The triad that you want to recognize here is Cushing's triad. Cushing's triad is going to be hypertension, bradycardia, and irregular respirations. Now, when you're mechanically ventilated and you have irregular respiration, you can have ventilator and patient dysynchrony. So let's go ahead and go through the pathophysiologic mechanism. Because of brain trauma, you can get neuronal swelling. That neuronal swelling is going to compromise your intracranial vault. In particular, you're going to have now high intracranial pressure. High intracranial pressure is going to be combated by an effort of your systemic vasculature to vasoconstrict. So that's why you get high blood pressure. You get a high mean arterial pressure in high ICP states because this is a sympathetic state. So your norepinephrine and epinephrine are going to vasoconstrict to maintain cerebral perfusion in the setting of your neuronal swelling. That increased vasoconstriction at the carotid baroreceptors is going to cause you to, via cranial nerve 9 and 10, give you an afferent signal to the brainstem to then give you an efferent signal of more parasympathetic at the SA node. And that's why you get bradycardia. So we talked about how the hypertension and the bradycardia relates to the baroreceptor reflex. And then because you can get direct compression of the brainstem, you have irregular respirations. So what are going to be some step 2 CK management tips for lowering ICP? We talked about hypertonic saline as one of them. Mannitol could be as well. Give me another way that we can reduce intracranial pressure in a patient who is exhibiting Cushing's triad. Go ahead and type that into the chat. What is another way we can reduce the intracranial pressure? Many of you are saying hyperventilate. Absolutely. So one of the things I do in the pediatric ICU, I elevate the head of the bed to improve the venous drainage. I make sure that the C collar is not on too tightly. The other thing is I give sedation because that reduces your cerebral metabolic oxygen consumption, and the patient is going to have less stimulation and activity, and hopefully that calms down the pressure. Hypertonic saline, which is going to extract the free water from the neurons. In severe cases, you call the neurosurgeon to perform a decompressive craniectomy or EVD placement. And then finally, you can also consider hyperventilation because the USMLE wants you to know when it comes to cerebral autoregulation, if you are going to hyperventilate a patient, you are going to cause cerebral vasoconstriction. If you have cerebral vasoconstriction, you then are going to have less intracranial pressure. So this is exactly how you want to think about pathology, both for step 1, but particularly for step 2. Remember that management is all about modulating the underlying pathophysiology. All right, we are almost done with today's session. Let's go ahead and go through this triad. A 68-year-old woman presents with her son with chronic progressive difficulty walking and, quote, getting lost. She describes her gait as feeling, quote, stuck on the floor. Her past medical history is notable for hypertension and a recent hospitalization for a urinary tract infection, which her son attributes to his mother, quote, constantly just dribbling urine. Her mini mental status exam is low, and her affect is noted to be depressed. What is the likely pathophysiologic mechanism? Excellent. Many of you are saying normal pressure hydrocephalus. This is typically due to impaired CSF reabsorption, but you are going to have the wet, the wobbly, and the wacky in the sense that they are going to have mood changes and dementia. Treatment is going to be acetazolamide, again, a carbonic anhydrase inhibitor that can reduce the amount of CSF production from the ependymal cells that are at the lateral ventricles, and then also consideration of a ventriculoperitoneal shunt, which is going to reduce the hydrocephalus. All right. Well, we are at the end of today's session. I hope you all learned a great amount. Let's go ahead and do a little bit of a cool down. And for this cool down, I'm going to put on my festive hat one more time. This is called my thinking cap. All right, here we go. What I'm going to be doing is I'm going to be showing you a triangle. The triangle has different vertices of the various vignette components. You tell me what is the diagnosis, okay? All right, very good. Disorientation, double vision, postural instability. What is this triad? I'm going to give you 5 seconds. This is going to be your Wernicke-Korsakoff. This is going to be a vitamin B1 deficiency. Remember, you're going to have ophthalmoplegia, you're going to have ataxia, and you're going to have confusion. Very good. All right, next one. Frequent falls, recurrent respiratory infections, spider-like blood vessels on the skin. Excellent. Very good. Ataxia telangiectasia. Remember, you can get ataxia. The spider-like blood vessels are going to be your telangiectasias, and you're going to get IgA deficiency, which presents as recurrent sinopulmonary infections. This is an issue with, again, DNA repair mechanisms. All right. A temperature that is high, headache, rash on the palms and soles, and I will also give you another clue, hiker. What do you think is the best answer here? Fever, headache, rash on the palms and soles, and hiker? Exactly. Rocky Mountain Spotted Fever. Very good. Here's a pediatric pathology, congenital pathology. Increased head circumference, inflammation of the back of the eye, and a CT scan showing intraparenchymal hyperdensities. So you have hydrocephalus, chorioretinitis, and intracranial calcifications. This is going to be toxoplasmosis. Remember that CMV, you get periventricular calcifications. So CMV equals periventricular calcifications. Toxoplasmosis, congenital toxo, you're going to get intracranial calcifications. All right, few more. Failed newborn hearing screen, decreased light reflex on eye exam, and a continuous cardiac murmur. Another congenital torch infection, deafness, cataracts, and PDA. That is going to be congenital rubella. Very good. Last three. Bilateral ankle joint pain, recurrent abdominal pain, and raised purple lesions on the lower extremities. Excellent. Many of you are saying Henoch-Schulin purpura. Absolutely. IgA-mediated vasculitis that is also associated with the colicky abdominal pain and intussusception. Very high yield for us to know. And also the palpable purpura on the lower extremities. Two more. Sun-sensitive rash, loose stools, and increased confusion. Excellent. Many of you are saying B3 deficiency, niacin, diarrhea, dermatitis, and dementia. Ladies and gentlemen, it's all about the application of the triads. You want to recognize it from a vignette and say, I've seen this triad before. What about this one? Learn, integrate, and apply. Well, that's the triad that I center myself around each and every USMLE lecture. This is the HyGuru triad. I am so proud of you all for sticking with me until the end. Just a couple announcements. If you haven't already, check out my pass-fail course. I am going to be linking the pass-fail course if you're preparing for step 1 or comp into the chat box. Also, I have a very cool Christmas gift, and that is a printout of and PDF that you can give to your fellow medical students when it comes to reviewing for the exam. It's kind of like a mini first aid that map directly to my lecture. So if you have the pass-fail course, get the book as well so you can have that book directly there for you to annotate. Finally, I want to highlight my Step 2 CK course. This is especially key if you're in clerkships and studying for your shelf exams. The data suggests that if you do well on your shelf exams, you can do well on Step 2 CK. So what I've done is broken it down by clerkships and given you a synthesized way where you can even have mapped UWorld questions to test your retention each and every step of the way for both Step 1 and Step 2. Finally, I want you to just take just a few moments today to write a review. I'm going to put this here. You can even put this review on Reddit or on Instagram, anything to spread the word. You know, I started this whole endeavor one medical student at a time, and I'm committed to that. Thank you so much for joining. Before you leave, I want to wish you and your family a very happy holidays and a wonderful new year. And please go ahead. One thing that you learned, besides my goofy hat, one thing you learned in today's webinar. All right, guys, mic drop. Very good. Thank you so much. I'm going to stick around for any questions you may have as well. Thank you all on YouTube for joining.